are going to start. I am Kathy Couch with Rewired 360. I am in Twin Falls, Idaho, and I am a certified thanatologist with the Association of Death Education and Counseling. We wanted to offer this free webinar so that we can go through some of the areas that we work on with grief. There's a model from the Association of Death Education and Counseling that we are just going to go over briefly on 6 areas. You can interact, ask questions. This is meant to be a collaborative situation so that we can all work together. I'm so thrilled that in our EMDR realm, we have Stephanie Pierce here. She's also certified with ADEC. So we're EMDR and ADEC people. So it's very rare gems. So I'm so grateful for her to be there. I'll let her share a little bit about herself. If you wouldn't mind keeping your cameras on so we can kind of see you and feel you, that would be wonderful. So Stephanie, I'll turn it over to you.
Hi, everyone. Thank you for being here with us on a Friday.
Yeah.
We're almost to the weekend. So I'm on the East Coast in the Pocono, PA area. Our ski resorts just closed then, and we're in bud season. I have a private practice that specializes in, of course, EMDR and maternal mental health. And I was lucky enough to have Kathy, who coached me to do the thanatology exam, which I have to say is harder than your licensing exams, but I did it too then.
It is, and if any of you are interested, we would definitely reach in pursuing that. We can definitely help you with some tools there as well. So, Lindsay, I just realized where I know you from, the basic training. It's so good to see your little face again. That's why sometimes I like to see the faces. So, welcome.
Good seeing you.
Re-meet you.
Yeah, absolutely.
So just kind of the format as we'll just go through the 6 areas of the Association Death Education and Counseling Crosswalk. Just FYI, we're going to record this. I don't know what we'll do with the content, but we'll record it and see how that goes there. So there's a crosswalk that talks to us as thanatologists about what areas to work on with death, dying, and bereavement. I'll go through those areas. If you're interested on how to interweave these with EMDR, we have a training actually next week on June 6th on EMDR with grief and loss targets, which is awesome. It's also available on demand. Stephanie has a sibling loss training, Stephanie, that you're doing in July?
Yes, July 16th through PESI, and then the fall, I'm doing it through just me.
A little bit easier route. And then we're working on doing a continuing bonds one coming up. So a few little nuggets for you there. And then we have our free EMDR peer huddle, the second Tuesday of the month at the same time. So if you have any questions or want to join, we'd love to have you. Okay, so the areas we're going to talk about today are dying, end-of-life decision-making, loss, grief, and mourning, assessment and intervention, traumatic death, death education, and it always freezes. And there's one more that's not showing up. Traumatic death, death education. I got them all. Okay, so we're just going to kind of go through this little crosswalk here. And Stephanie and I will take turns here presenting this. So I guess I could go first. Stephanie and I will just kind of go through each of these areas. If you have a specific situation that you'd like to discuss, we're happy to help you. Happy to help you there. Anything I've missed, Stephanie, before we start?
No, and then Brenda had a good question about the exam. So it's and Kathy, you're better at it, the ADEC, you're better at acronyms than me, but it's
Association of Death Education and Counseling.
Thank you. So there's a certain amount of, which I'm sure a lot of you have, the hours that you need that are direct contact, similar to a licensing exam, your face-to-face contact with clients. Then there's a certain amount of hours you have to complete of CEs and death and dying and bereavement education. And then like a licensing exam, you do have to sit for an exam, register and sit for an exam. that you do get to take in the privacy of your own home, but there's 2 textbooks that you have to use to prepare for it too then.
Here's one of them, the Handbook of Thanatology. This is probably an older version. So if you want to sound really smart, just tell people you're a thanatologist or know what thanatology is. It's a study of death, dying, and bereavement. Who knew? So it comes from, I'm a super nerd, but it comes from Thanos, who is super popular now in Marvel movies, for his view on death, but it would actually occur before him, but it is a Greek root. So I think that's kind of a fun thing. And so there's a couple other books there, but it does take a commitment. But it's worth it to be able to go through these areas as well. They also have, after the certification, you can also be an FT, which is a fellow in thanatology, meaning you can teach it, more of a research kind of credential. But I don't want to do another test, so I don't want to do that. So, but the EMDR basic training you can do my EMDR with grief and loss targets. You can do any suicide training. So that will also qualify, I think, what, Stephanie, 40 credits or something, 40 credit hours. Then some recommendations from colleagues and letters and those kinds of things. If that's something that interests you, let us know. We would love to build a community of thanatologists. That would be an amazing experience. So that would be cool. Okay, dying. So we're just going to kind of dive in. So as we think about working with patients that are dying, so more in the hospice realm, and you're working with any kind of EMDR target or people that might be experiencing it on the other end of dying situations, we're looking at some cultural issues. So sometimes healthcare interactions, of course, being in the hospital, being on hospice. Of course, any other experiences that you've had with this scenario, feel free to share. As we know, family roles can shift. That could be a possible target that we can work on, and figuring out how you work on those religious and spiritual death rituals with dying. How do you honor the needs of the person that's dying? Maybe the family has a different cultural or religious perspective that they may be imposing, could create a target for our patient. Decisions. So when we think about our EMDR targets here, we're all coming in. Just going to keep a brief eye on my email so I can make sure the link isn't working. So those are some of the things that we'll just kind of start with. Stephanie, you have comments there? Anybody else have comments there?
And for the dying part of it too, we're also preparing, it's the phase 1, phases 2 work for EMDR, the dying. Also, this is where we resource clients to say, what do you need for yourself during, as your loved one relative is dying? This is where we do our resourcing, like our, again, like how do you take care of yourself with knowing this is approaching too? And also, I don't think we think of this too, but the licensing or the exam for thanatology, I like how it's thanatology, and yet I've had trouble saying it. So the Thanos thing really helps because I've usually tripped over the word thanatology. But I like how, even though it's like a nerdy exam, how they really did hone in on death, and it's death, dying, and thanatology is the study of death, dying, but also life and living too. And that's really with the crosswalk, what we're working towards. It's like, yes, we're talking about loss, but then we're also talking about life and living too. And it's how do you honor yourself then during your grieving process and your loved one.
Yeah, so if you think about that from an EMDR AIP model, right, it's really cool because you have your targets on that one side, and then you have the adaptive life and living, right, part as well. Isn't that amazing? I just love that perspective there. So that was wonderful nugget there. Okay, professional issues. So with dying, so working in hospice, working with a hospice caregiver, fatigue, burnout, attitudes towards the dying.
Okay, love you. Bye.
We love you too. And thinking about people in hospice, any of those professionals, we're working with those professionals in the area. Any kind of thoughts as we're thinking about working with people who are on hospice, family members, professional issues you've worked on, things we may be able to offer you? Any kind of professional things maybe that we can work on there within the group today? Feel free to just let us know. Then we have historical perspective. So depending on where they come from, the dying rituals are different. I did a study abroad in West Africa during my undergrad, and there was this woman in the streets wailing, and I couldn't quite understand because in American culture, that means something different. Usually there's an emergency or a tragedy, some sort of first responder response. And my instructor so graciously said that's the way they mourn their dead. So the public display of mourning is a cultural expression. And so thinking about working with patients within those areas, how we work with those historical perspectives. As we know, with dying in the pandemic, I think we have a more present view of dying. I know a lot of us as healers and caregivers and clinicians, right, had probably more exposure to dying populations and scenarios than we had previously, and also personal lived experience as well, probably at a rate that we've never seen. And so being aware of our own triggers when we're working on with dying and bereavement, when a patient comes in experiencing some sort of issue with the scenario, we have sudden death in there, unexpected death. The target could be, they were so young, it wasn't supposed to happen this way, as we've seen those areas. When we go into the lifespan, oh, sorry, let me share my screen here. When we go into the lifespan, we look at these areas of normal developmental processes. So a lot with children, young family members. This person was so young. They didn't reach this developmental task of, graduating, getting married, maybe going on their first international trip, something like that. So you see a lot of this when working with dying. If you're looking for a target for somebody in the scenario, those are some of the things that you can look at. Children lie under special populations, addiction. There's a whole different scenario as they're actively dying and you can see it. And so there's a whole different grief process, I think, from people and families working with those challenges. We have institutional and societal scenarios, the impact of politics. So you look at things like assisted suicide, those sorts of policies that guide our decisions about how the dying have rights. When do they have rights? So all these themes of responsibility and decision making in EMDR. We've spoken about this a little bit before, the family roles. Is it sometimes the females are just, in one of my situations, there's a person that's disenfranchised from a certain religious family. However, she's still expected to perform the role at the funeral. Even though her brothers have
Oh, girl.
disenfranchised her, told her she didn't matter. She's still expected to do this role because she's female in the family. So that was difficult, those kinds of things. As we look at resources and research, just being able to stay up to date on research findings. We can even this can work with pets. It doesn't just have to be a human. It can be any other type of dying situation. I know my little dog almost died. I think it's a year in June, maybe it's 2 years. I can't quite remember, but it was still very traumatic because I love him and it's taught me every day to just look at him and honor him more. So we talk about that with continuing bonds. Stephanie's a great way to do that. So that's kind of the issues with dying there. We'll go ahead and display this at each category. We're just going to stop the share for a second so we can return to the group. So as we talk about the issues with dying, how can we support you today in working with patients that are experiencing issues with dying? what thoughts are you having? Questions, clinical considerations, points, things to
Yeah,
offer?
I'm currently working with a client system that is her son completed suicide a year ago. And she had worked with a grief counselor and they just felt like she was stuck because of the anger and the hurt behind this, the trauma of seeing the suicide. Um, and so she referred her over to me to do the trauma work. And I can tell you that it's really made a big difference in having her be able to process the actual scene and all of that. So now she's getting away from that whole frenzy and finally able to start grieving. And so I was really curious as to how and why that plays out. And just that's what piqued my interest in this course, was just wanting to know more about that.
Yeah. Stephanie?
I was gonna say what was probably different was you, Brenda, was one of the factors, because I'm noticing like how the other agency was saying stuck, and which is where you probably validated like what a tragic, horrific death this must have been, and the meaning of like this death for the mother. And so I think you probably validated that, and that there's no like stuck, that's not real. Like I'm just guessing that maybe that like evoked shame for her, or like how you should do things then, or like you almost get a report card for grieving. So I think the difference, Brenda, was probably you, or as the therapist, was a big factor, and you gave this client space and didn't, and said like, oh, gradually we can move from the maladaptive network where you're just seeing that how your son died and that trauma to, and we're going to move you gradually and safely over to that adaptive network where we continue your bond and that relationship with your son then.
Yeah. Other comments here?
Thank you for those kind words. I don't know that it was me. I think she's just at the point where she was being brave.
Right, you facilitate. I'm guessing you facilitated that, and to say there's no judgment too about how you're grieving, because saying stuck is like
Yeah.
we're putting a judgment on where you should be. And I mean, on the other hand, with grieving, like, yes, we don't want clients to simmer in it, meaning that they are suffering, like they have trouble sleeping, like they're not eating. Like, we don't want any of our clients to suffer. So I say to clients, I don't want you to simmer in it, but I want you to experience your grief. But we want to like pendulate back and forth between like that dual process grief model where you're recognizing your loss and you're sitting in it. But as the helping professional, I also don't want you to suffer. And I'm also going to help you pendulate to present, and how can we support you, and what are things that can maybe give you comfort then.
And
So
I
I
don't
feel,
know
Brenda,
if
you sound like you did that.
I'm a good EMDR therapist, but I love the dual process model,
Mhm.
right? Because we're holding both together. It's very bilateral, isn't it? And so I think that's amazing to hold those together. I think as I'm listening to what you're saying, Brenda, it's like holding both of those
Yep.
spaces together with EMDR. So what happens with EMDR is she was activated so we can get into the imagery. And I think your specialty and sincerity to approach that. And I think Stephanie made some great points about how do we discuss it. I was in another group setting and somebody said they committed suicide. So just that education around died by suicide, completed suicide can really ease that. So this point of nerdiness, committed suicide is a historical. You love me, Messina. It's just, used to be illegal, actually a crime to die by suicide. So that's actually historical language. And so when you say committed, it's implying that there's an actual crime that's occurring by dying by suicide. So if we can even use those simple languages, like Stephanie was saying, that's just the language to discuss the scenarios can be psychoeducational for ourselves and peers. Very important as we share about the cases. I think just the nature of EMDR, right? You're targeting the image, the memory, the body sensation can just facilitate that adaptive processing as well. But she was attuned to you. So please validate that, Brenda, that we have to be attuned and safe for them to do the work. Okay. Okay, so now we're gonna move.
A question, real quick one. With complicated grief, this client is really struggling with the sudden death of her sister, who was really significant in her family system. I don't think she can tolerate EMDR, but the flash, would you suggest that the flash technique would be applicable for a more gentle introduction? Because she has images, and they're really paralyzing.
Yeah, the way I kind of like conceptualize what Flash is EMDR is a road trip, Flash is an airplane ride. So if you think about the airplane, introduce the airplane, see if they can even tolerate a little piece of it. You can also try the intervention EMD, EMD little r, and EMD big R. If you're not familiar with that is, there's a great video on YouTube from the Morrissey Institute, Dr. Michelle Morrissey. But in essence, the EMD is just focusing on the initial protocol that Francine Shapiro introduced, with EMD just being the desensitization and no reprocessing. The EMDR little r is just a little component of a piece of the situation. You're not opening it up to all the memory networks, which is a big R. So there could be a little piece of that as well. And I would also encourage you to think about, just because we're not doing reprocessing doesn't mean that we're not doing EMDR. We can be in phase 2. We can teach them resourcing. I definitely suggest trying all of those interventions to see if she can just see it, contain it, and try to see with the flash if that works. But yes, trying all of our tools in the toolbox there is definitely important. So
Thanks.
You bet. Yes. We're going to move on to end of life decision making. Stephanie, I'll pull this up for you if you want to go ahead and chat about that. You can.
Yeah, can I go? I just want to comment on the sister loss. It was a sister then from the.
Was it?
Yeah, it was
Okay, so
a sister.
just to piggyback on what Kathy said, for resourcing, you can actually, if this is tolerable to a client, where there is those like the more complicated grieving, the traumatic memories, is during resourcing, like you can resource and install, like with the slow bilateral, the sister smile, like there, like a childhood memory if it's not too activating. Like if there was like the sisters touch, like if they like music together, resource all of that then with the slow bilateral, and that's going to use them into more the traumatic memories if they could tolerate the positive memories.
I love that. Yeah, thank you.
I resourced the Millennium Falcon for a client because that was a connection to a brother, and I was like, go it, let's resource that.
Yes, great stuff.
Go with that.
Oh, yay. All right, you're up, Stephanie, on the end of life decision making.
I was just telling Kathy about the end of life decision making in this category. So this is where, as the helping professionals, we can do prior to reprocessing the psycho ed piece too of anything end of life decision making that could be triggering for a client or a family member. And just for example, I had a new client where the end of life decision making, there was a mother that was in hospice, and hospice may have spoken about what was going to happen after the mom died at home, but I don't know if it was in terms that my client could understand. So they didn't understand what was going to happen or know after the mom died at home. Like how the mom was going to be taken out of there, like that you would have to call the funeral home. So when the mom ended up dying, there wasn't like these end of life decisions that were even like, who's going to call the funeral home? Like, what can you expect after the mom, dies at home? What do you need to know? So we're preparing and giving the psycho ed to prepare for, well, is there anything like your loved one wants? Any questions you have of what can happen if somebody does die at home, in the hospital, if somebody does say that they want to end care, or it's like compassionate ending of certain medical interventions. And we're doing that psycho ed piece too of what, maybe you want to understand, what's confusing. So also kind of hopefully head off, like anything that could potentially be traumatic then. So this is category where like doing a lot of psycho ed, any questions that maybe people are afraid to ask about end of life, what dying could look like, where helping them in a safe way explore that then as well.
And if you're thinking about the targets, right, responsibility, control, safety, defectiveness, all of those end of life decision making hit all those clinical clusters, right? Because who is the decision maker? And sometimes it can be, I think there's a lot of material around there. So the intent of this is to be able to help us think through, if we have patients experiencing these things, why can't we get this processed, is to offer other ideas and strategies so that we can help them. Is that, Stephanie? Do you want to cover the crosswalk or just give me?
Yes, say too with the end of life decision making too. This is where our EMDR future rehearsals, and I don't want to say we're rehearsing what's going to happen when someone dies, but we can rehearse and install if needed what somebody's going to like have a conversation they might have with like a relative or a care provider around like sensitive subject area or something that's difficult. This is where we can do our rehearsals or future templates and then throw in obstacles and this is the category where clients, if they're afraid to ask something, we can bring that into session, or if there's something they want to know about the dying process that they're afraid to ask, we can cover that with this category.
Yeah, good. And I think the next one is loss, grief, and mourning. I think as we look at the DSM, there's criteria for complicated grief. Do we put it in? The big question in the grief circles is, do we pathologize grief and give it a DSM diagnosis? It's not a mental health condition, and the rub is, how do we treat the patient? We treat the symptomology, the presentation, anxiety, traumatic stress. Is there enough to provide the diagnosis to treat the patient with grief and loss? Do we have to pathologize it itself? I don't really land anywhere on either side. I'm still I know people who are really like, no, do not pathologize, or yes, we need it to treat. So we get into these clinical questions in the grief, loss, and mourning. But really what we're doing here is treating the affect, teaching them how they continue the bonds with the people. Freud, when he started this idea, was that, death ends a relationship. Now we have death ends a life, not a relationship. So we're really transforming. Now we have lots of, help me out, Stephanie, resilience models, the post-traumatic growth models, that you can have a trauma, still grow from it. Some of these more restorative healing adaptations and response to grief. Now than more, there's more of a community of grievers, I think, even collective grief. As we go through these ideas, as we're thinking about you can think about the client's culture, what are the death activities? Is there a wake? Is there, I didn't get to speak at the funeral. I didn't want this pastor to present. My sister talked at the funeral. I was supposed to, but really just the idea between grief and mourning. So just thought for the audience, any kind of comments or knowledge on the difference between grief and mourning? Stephanie, you can't answer.
That was a test question on the ADEC. That's a test question if anybody's going to take the exam.
Just behavioral clinical question. Do you want to tell them stuff?
Oh, I was going to say this category too, is where somebody didn't get to do a eulogy, or like for resourcing, you can do that in this category in session as well. And this is where working on this aspect, if grieving looks different in family members, which it's most likely of going to, is where when we're resourcing that, we validate that as well when that comes up, which is a lot of times what comes up with family work then too.
Yeah. So I think grief is the emotional expression, the presentation, the emotions that occur. The mourning is the behaviors, right? So with my lady in West Africa, she was mourning. That's how they mourn the dead. I'm like, oh, okay, that makes sense now. Those are these behavioral rituals that occur. And so is the patient that hasn't gotten over or is stuck, are they actually stuck or are they just mourning their dead? And there's a fine line between the external explicit memories, which we can see, and the implicit memories, which we can't. And so that's what we do in EMDR, is work on explicit and implicit, and the normative grief responses and the impacts of the type of loss. Of course, when we get to traumatic death, is expected, unexpected, these sorts of scenarios, we think about the shock factor and the polyvagal and the nervous system and those sorts of scenarios. So that's kind of, as we look on that, and what are some of those stigmas and bias there. Okay, assessment intervention. This relates to caregiver roles. Stephanie, if you want to kind of talk about that.
For the assessment and intervention category too, this is where, again, our advanced care planning we talk about in here are the cultural competency, and even exploring in this category if like that experience, if like those needs were taken into by the like medical staff, providers, we're doing assessing for the impact of like a death on a family system, role changes, assessing a secondary losses, meaning like if for an example, I'm working with a client where his wife died suddenly and he called himself the per diem parent because he kind of let the wife did most of the child rearing. So in looking at that, the change in that role and that secondary loss of having like, yes, the primary loss of his wife, but then the secondary loss of like having someone who kept the household together, and we're assessing for that and supports then those again, the assessment piece with those gender roles came up with that case too. This assessment and intervention, we're talking about our informed consent, as well with like medical procedures. And I mean, that could go through, okay, I think through the crosswalk too, Kathy, though.
Yeah.
Some of these do overlap a little.
Yeah, and I think when we're thinking about this, I had another case to where, okay, so there's a mother of three, oldest son, has antisocial personality disorder, lots of difficulty in the home, so resulting in stress with the other two children. He punches her in the chest, these kinds of scenarios. And so then he's a member of a certain faith. She then in turn leaves the church. And so now she not only doesn't have a relationship with him, and so now this is a type of disenfranchised grief, to where she grieves the loss of the relationship with him, but it's also not validated in the communal context. And so you can think about that, young widowers versus other ages of widowers, these types of disenfranchised griefs which aren't readily expected. How do you intervene there? That's kind of the purpose of our work, Stephanie and I, to give you guys little different angles to maybe go in on as far as EMDR targets, other ways to be able to look at some of those non-recognized stigmatic ways, right? Okay, now we'll move on to traumatic death, which I think we mostly see, as trying to get this here. I guess we'll just have to leave it at the bottom. Maybe. Sorry, I'm trying to get my screen correct here. Okay, so traumatic death. So what often happens is I would say this and hospice are one of the reasons people seek out therapy the most, in that shock phase. This happens to where like even people that may have a mental health stigma against accessing care might be forced to come in to see a therapist, receive an intervention. There's a familial, there could be another, like communities with, in our community, children dying by suicide in schools. Then there's a communal context, of the way that we respond to that grief. And so that can be secondarily traumatic to the staff at the school, the children, even if they weren't there at the event. How do we provide support in those arenas? So you could have a child there. We had a scenario here where, thank God, there wasn't an active shooter, but we had to go through the drill, one of our local schools. And so lots of patients were reaching out, asking for help and support, just coping with the idea of how do I go back to school with this intervention, knowing that this might have occurred. So there's a lot of secondary things. I think we look at these areas as primary targets for EMDR. What are the secondary targets? How do we consider the way that they're impacting the patient, the vicarious traumatization, even as a therapist, hearing the stories, getting the, having to work on our own desensitization. I worked in child welfare. And so, I worked with this patient, this case, and a lot of the clinicians that had just went to the, involved in the case, went to the funeral. And I, as a worker for a couple of years, didn't go, but I didn't know I could go. I didn't know like that professional boundary. And so really kind of getting support as clinicians to understand, like, when a traumatic death happens, what's the appropriate response there? Do we go? Do we not? How do we support and not break confidentiality, ethics, those kinds of considerations? Stephanie, other comments here?
For the traumatic death domain, this is to where through the AIP lens, the resourcing becomes like really, not that it's not important, but it really important where as helping professionals, we're the people who can be present for our clients and then tolerate hearing about parts of the traumatic death that maybe a client hasn't shared with other people. For example, I have a client that had her son was born stillborn, and she wanted to use sessions to say, like, this is what happened. There are certain aspects that my husband didn't know about, and this is, I want to be able to tell you, and just have somebody bear witness and keep it in this room. And then one of her targets evolved into her reading a letter to her son about like that they're always going to have a connection. And then we just use BLS to install that letter then.
I think, Stephanie, you're really on to something there. We'd love to work on trainings to where we see the early death of children. I had a patient, who went full term. This is all the things about pregnancy and loss and bereavement, I think could be a very beneficial training. Therapy. Stephanie's kind of an expert in maternal mental health, so we appreciate her for that. I think I heard in an Adlerian training one time that the loss of children is a disenfranchised loss that people don't recognize sort of pre-birth or in utero, these ideas of what happens now that we're taking away the right for mothers to end lives in utero. How does that impact the health of the birth, the relationship of the child that's born? How do I, deal with this baby now? And I have 7 other children. This is my 8th child, or just health concern. So we're probably going to see a little bit more of those kinds of scenarios, I would anticipate. Or just coping with the political structure that we're in, and being able to kind of work through those decision makings as we look at, again, the clinical themes of responsibility. Those rights to choice are taken away. And so how do we deal with those targets and those traumatic deaths, or even the deaths of the life maybe you thought you would have? I say this kind of in jest, as I figured out I had twins right before the pandemic, February 14th, 2020. So even those like unexpected multiples can be distressing, I couldn't leave my house. Nobody could come over and celebrate them. They were sick, with it COVID. So all those things during that time, sometimes we don't consider can be just issues in themselves. And, am I doing enough for my own children there? Okay. Deaf education. Stephanie, that's you.
Yeah, this is a big topic though, too, because we're in a death phobic society. So even the death education, this is where all of us come in to be able to the psycho ed piece with our clients and be able to answer questions or anything again, because we don't live in a society where you can ask about the dying process freely or have your fears discussed. So even the client's fears, we can target that through the AIP lens, even if it's a fear of dying, what that really means underneath for them. Like acknowledging too for resourcing that we are, again, we're a death phobic society. I think even for helping professionals, it's not a required course, death and dying. It's usually an elective. If I believe that that's still true. This is where we can then get like resource and get our clients like the needed referrals, talk about the lack of education or something they wish they knew then too for resourcing. But this one I'm like, ooh, death education. This is something I think is like a missing piece and even like helping professionals in our education too.
And even working like with people like the mortuaries, like it's hard to go through a process and go to a mortuary and interact with that business as you're grieving. I think the morticians and the funeral directors that really have to have a kind presentation. I think there's also, not to get off topic, but an example here where we had just a funeral home that didn't necessarily provide the remains of the loved ones. And so they were caught, misusing and mishandling the deceased bodies. And so then secondary trauma at the funeral home of like, is this my loved one? Where is my loved one? Like, how this institution I'm supposed to trust has been, fraudulently, doing things with their remains. And so how do I deal with that sort of kind of issue institutionally or societally or culturally? So really just kind of bringing this to the forefront of like the grief groups, the grief education. We do have a couple of grief support groups where I live. So just becoming familiar with those resources. Alan Wolfelt has a really great curriculum working with grievers. I work with children because kids grieve, a nonprofit. So being aware of the resources in your community. We have like a grief camp ages 6 to 17. So being aware of where those are, where you can refer them to. They'd much rather go to a camp than be in therapy at that age, right? I would too. And so I think just educating yourself on a couple of referral places. There was a widowed wellness group in my area, even national ones. David Kessler had an online grief forum after COVID. He has a lot of resources there. So grief.com is a resource. What's Your Grief is Eleanor Haley and Litza. I forget her last name, but we've had them out here to present on how do you work through grief as a process, have a lot of good resources. So just having a couple go-to teaching tools, I think, as clinicians to refer them to, whether it be videos, resources, books. I like this book, You Can Heal Your Heart. This is by David Kessler and Louise Hay. Finding Peace After the Loss. I think there's also a 6th stage of grief that if you're not familiar with is up and coming. So that's good. There's this other book that's kind of like a little well, it's just a little risque, but it's called Welcome to the Grief Club. I definitely recommend you look at it before. It just kind of talks about grief from a psychoeducational perspective. It has lots of like pictures and stuff like that. that have been really good. So just kind of having a little bit of a toolkit. You don't have to have a lot. And so it just depends on the brain that's in front of you as far as what they like and enjoy. Some people need tactile, some people need visual, some people, whatever those self-soothing resources are. Just have a few in your wheelhouse so that they can have those resources there, I think, Stephanie.
Yeah, for this category too, and I'm gonna say bibliotherapy, although I had a client was like, is that a real word? Bibliotherapy, we can zoom out to mean more than just books, but resources, social media sites. So that's for this category, it's a go-to quick resource though, if clients, if they are leaning more where they are like activated and feel like they're suffering. It's a bibliotherapy. And again, I acknowledge it's a broad category now. It's something, it's a go-to resource. Like, oh, let's pick up, like if you're home and you're feeling really activated, let's pick up that David Kessler book where you liked that quote and you found that comforting. Or, oh, let's like remember like art therapy or gush art, remember you like that as a resource and this was the book we found that in, or the social media site. So that's a quick like go-to resource that can bring down activation pretty quickly.
That was brilliant, Stephanie. I've never heard of that. That's actually an amazing concept as you think about that. Okay, so that's kind of the areas maybe that you can think about when working with grievers, when considering this. We're just going to open up now for discussion and commentary. We'd love to hear your thoughts, what you would like to hear more about, things maybe that interest you, other resources you have, really just anything. I'm going to go ahead and stop the share there. So I had never heard of the Association of Death Education and Counseling. I don't know how you came across it, Stephanie. It was just through another clinician with the having that credential that I discovered it. Even when I came to EMDR, I've been working in grief a lot, and there's this pressure of like, what's your niche? And I'm like, I don't know what I'm doing. You get caught up in it. It's like, oh, I already have this other certification. So we could like get flooded, sometimes with like trying to figure out like who we are as an EMDR clinician. And I think, just really resting ourselves in that too. Stephanie, how did you come across that?
I think I had another, like you said, another therapist who said, oh, you probably have enough to get the CT, the certified, see, I said it right, thanatologist. I actually said it right today. Certification. I said, no, I don't have everything I need. And then it turned out I did, but it was just sitting for the exam. And then Kathy, who mentored me and encouraged me to actually sit for the exam then too. But that most probably a lot of you have what you need to be able to get that credential too and don't even realize it.
If it's something that you're interested in. So that's kind of the intent. We have a lot of these webinars. Stephanie and I are just going to be doing lots of fun stuff now that we found each other. It's been really fun. I know that Roger Solomon has he's done a protocol. There's this Marilyn Luber. She is like the protocol expert. I don't know if you guys have ever heard of her. A guide to standard EMDR therapy and protocols. There's one in here. I believe this is I'm sorry. Wrong book. There you go. Scripted protocols. And she has a protocol. If you just kind of like don't know where to start, it's a protocol for those excessive grief. It's from 2001, but it gives sort of a summary of the protocol. Working on the template, it gives you some questions. What are moments or events that stand out concerning their death, the incident, the picture, and then going through the phase 3 setup, and intrusive processing nightmares, present triggers, And so issues with mortality. And so that's a really good, just kind of way to start. If you're looking for something that you're like interested, but don't quite know the language. Marilyn Luber is a really good resource. She also has that resource if you don't want to buy the book, if you can just Google it. And if you can't find it, just email me and I'll send it over. But those are two EMDR specific resources. They're pretty much I don't want to say the only ones, but they're very limited resources, and we're hoping to continue to advance this so that we can continue to provide more education. Stephanie and I are going to have more trainings on each of these areas. We're going to partner together to bring more specific to you guys so that we can really enhance our skills. I think the work with veterans and first responders is coming to the market more. So I think just all of the things. So I just want to acknowledge everyone. I really just am so grateful to be with you all, trying to do all of this work together. It really is important to me to see your faces and to be with you doing this work. It can be very difficult work at times. Going to these scenarios and situations, there's an expectation people have for us. So even working with grievers, just remember it's okay to just sit and be attuned. You don't have to do any magic, right? I think that's really important because people have an expectation. I had this trauma fix me, and it's like, okay, it's going to be a process there. So, Stephanie, anything else before we end today?
Yeah, thank you everyone for talking about death and dying on a Friday afternoon.
Yeah, I'm kidding.
Can you
But
guys
for most,
remind us of the upcoming trainings that you do have coming up?
Yeah, I'll just pull up my website here real quick.
I'm going to put my email in the chat too.
So you can go to my website here. You can find all of these here, but mine's at rewired360.com. You can go here. We have one next week on Friday, April 19th. It's live. You can go here and go to trainings, and here's your grief and loss targets, live, virtual, and on demand. We have a refresher course that will be offered later this year. We've done the live one. But here it is, April 19th and June 6th. Those are live. And then as we work on each of those categories, Stephanie and I, they'll be posted here. We did get approved for CEs now. So excited. Yay. So they're EMDR credits and CEs. So more worth your time there. It's what did I put the price at there? On demand is $189. If you wanted the CEs, it's $209, and without should be without CEs, it'll be $189. Oh, it's right here. So that's kind of our courses there. We have virtual and on demand, and we will also just any resources. Stephanie and I are open to just helping consult with any of those cases or stuck points, and helping us think about how do we do this very important work, and be able to move that forward. We have a free peer huddle every month, Tuesday, second Tuesday of the month at 11. You can register there as well. So if you just want to pop in, have a question, that's no cost to you. There's a Rewired 360 community resource library, and all the things. So that's kind of where we're at. Other things we can help you with? Steph, anything else?
For if anybody's interested, the sibling loss training is going to be through PESI, July 16th. And then I'm doing another one through me in the fall. And then Kathy and I right now, it's going through ASWB approval, but we are going to be doing a continuing bonds training. So if you email me to be put on the mailing list, the only thing you would get would be when the actual training is going to be. I wouldn't inundate anybody with any emails because I still have to clean up my own inbox. And then also we would give you coupon codes for both the sibling loss and the continuing bonds training. Not the PESI one, I can't give a coupon, but I can do when I offer it in the continuing bond ones too. So just email me if you want to be on the mailing list. You can always remove yourself, but I promise I won't do a lot of emails either.
And after this session, you should get a coupon code. I believe it's 30% off any of those trainings on my site, whether it be grief or refresher, or you want to get certified or be a consultant, anything I offer. If you're not a member of the resource library, you'll get that, and then you'll get a coupon code. I can't remember how much it is, but you'll get a coupon code for one of those trainings. Oh, also there's a case conceptualization kit on my website that goes through those 6 areas. And it has a workbook. Stephanie's using it in her practice as well. So we have that resource to just help you work through that. I don't know why, didn't think about that, but we do. So that was a labor of love as well. So we just so appreciate you all. You all are just very important. You always have a home here. We're just here to let you know that you matter and we see you, and everything you do is seen and heard, and really, we appreciate you all. So we're here for you if you need anything. Other than that, our time is up and we will see you next time. Okay, bye everyone. Yay,
Yeah, good job.
we did it. I'm gonna end this recording.